Today, across America, insurance companies are selling mental health coverage to our people worried about their mental health or that of their loved ones. Unfortunately, too often after these insurers take big premiums from our people, they let them down. The providers they advertise aren't available. They can't get appointments. The firm basically says we aren't taking new patients, which of course was not represented to them initially in that way. The fact is, these Americans are being ripped off by what the Government Accounting Office has described as a ghost network. Not my language, the language of the Government Accountability Office. Now, to me, what a ghost network is all about is essentially selling health coverage under false pretenses, because the providers who've been advertised aren't picking up the phone, they aren't taking patients, and in any other business, if a product or service doesn't meet expectations, consumers get a refund. In my view, it's a breach of contract for insurance companies to sell their plan for thousands of dollars each month while their product is unusable due to a ghost network. And so I'm going to work with all of my colleagues here on both sides, Democratic and Republican, to get some real accountability for these patients who paid good money for mental health coverage and they find that there is very little there. And in a moment of national crisis about mental health, with the problem growing at such a rapid rate, the widespread existence of ghost networks is unacceptable. When somebody is worried about their mental health or the mental health of a loved one, it's hard to work up the courage to step up and try to coordinate their care. And if they can't get help, the last thing they need from a big insurance company is a symphony of please hold music when they call, and non-working numbers and rejection. I think we can all imagine, because we're all hearing from our constituents. I'm looking at my Republican colleagues. I've talked to almost all of them personally about this mental health challenge, and we've been working on it together. But what I've described is not a hypothetical matter. Last month, my staff conducted a secret shopper study. They made over 100 calls to make an appointment with a mental health provider for a family member with depression. And they looked at 12 Medicare Advantage insurance plans in 6 states. The results were clear. Our secret shoppers could get an appointment. Now, this is after people had paid vast sums. They could get an appointment only 18% of the time. That means more than 8 in 10 mental health providers listed in these insurance company materials were inaccurate or weren't taking appointments. A third of the time, the phone number they called was a dead end completely. In one instance, staff trying to reach a mental health provider was connected to a high school student health center. And Senator Cassidy is a real pro at all this health issue, and I think both of us would probably say we laugh, but we really feel like crying for the patients, and I think it's kind of representative, of it. By the way, in my home state, I'm not very proud of what our investigators found there too. My staff didn't find that we could make one successful appointment. Other secret shopper studies looked at commercial health insurance, found the same thing. In 2017, researchers posing as parents seeking care for a child with depression got an appointment 17% of the time. 2015, pretty much the same results. Ghost networks are an ongoing, persistent problem. The Finance Committee has been looking closely at this issue, and we put a lot of sweat equity into developing legislation to improve mental health care for all Americans, from telehealth to youth mental health to workforce to care integration and parity. And I can look down the row, starting with Senator Crapo, to my Republican colleagues, because we have been working on this in a bipartisan basis. And we've got plenty more to do, as Senator Crapo and I talk about in our weekly conversations. Finally, just looking at the ghost network issue to wrap up, it's a three-legged approach. We've got to have more oversight, greater transparency, and serious consequences for insurance companies that are fleecing American consumers. And I believe certainly greater transparency, for example, ought to be an easy one for members of this committee to get around. I don't know anything about the accountability you get with transparency being a partisan issue. So I want to work with my colleagues on that issue, on the accountability questions, and I want to look at this across the board, not just with respect to Medicare and Medicaid, and many of my colleagues have expressed interest in applying policies to commercial insurance like employer-sponsored plans. So we've got a lot of work to do. There isn't going to be anything partisan about it, and let me yield to my friend, Senator Crapo.
Thank you, Senator Wyden. And, you know, it's no secret to anybody that you and I have prioritized mental health delivery in America. In the last Congress, we got a number of major initiatives through and signed into law, but there are a number of major initiatives, such as this one, that we still have work to do on. And I appreciate the opportunity to work with you on it. Last Congress, as I said, we came together to enact dozens of bipartisan policies to expand access to mental health care services. These reforms will increase the number of providers participating in Medicare and allow patients to receive care in more convenient locations, including through telehealth. However, in order for these improvements to achieve their potential, patients need accurate and up-to-date information on their health care options. I've long championed Medicare Advantage for its ability to offer patients choice and control over their health care. Through robust competition and innovative benefit offerings, Medicare Advantage provides consumer-focused health coverage to millions of Americans. As enrollment continues to grow, improving the accuracy of provider directories could further strengthen Medicare Advantage. The patient-provider relationship is the foundation of the healthcare system. Whether a patient is suffering a mental health crisis or just received a troubling diagnosis, directories should serve as crucial tools to help seniors across the country. While we work to better align incentives to improve provider directory accuracy, we must also do so without increasing burdensome requirements that will only weaken our mental health workforce. Regulatory red tape and reimbursement strain, among others, can also decrease patient access, exacerbating physician shortages, compounding burnout, and eroding healthcare access and quality. Congress should build on their targeted relief measures, like the ones we advanced last year, including temporary physician fee schedule support and Medicare telehealth expansion to address these issues on a bipartisan and sustainable basis. Physician payment stabilization and telehealth coverage for seniors have received strong support from members of both parties in both chambers. As we look to enhance Medicare, we should prioritize these and other bipartisan goals, and we must do so in a fiscally responsible manner. I look forward to hearing from our witnesses today about the opportunities to streamline and improve provider reporting requirements, empower patients, and give them accurate information and advance more transparent health care system. Thank you.
Thank you, Senator Crapo, and you have certainly laid out a number of areas where we can continue our bipartisan cooperation. Look forward to pursuing it with you and with all our colleagues. Let me introduce our witnesses briefly. Karis Myrick is Vice President of Partnerships at Inseparable, a nonprofit organization working to improve mental health care. We welcome you, ma'am, and I know you're a leading mental health advocate and executive. Dr. Jack Resnick is here. He's the president of the American Medical Association. Good to see you again, Dr. Resnick. I know you're a professor and chair of the Department of Dermatology at the University of California in San Francisco, and you and I have been in healthcare discussions a number of times over the years, and we're glad you could be here. Robert Tressman, PhD, MD, comes to us at the recommendation of the American Psychiatric Association, an organization that's been at the forefront of mental health parity and provider health accuracy. We welcome you, Dr. Tressman, a long relationship with the American Psychiatric Association. Mary Giliberti, JD, serves as Chief Public Policy Officer for Mental Health America. She's also author of an important blog series called Designed to Fail, looking at how these powerful special interests determine the quality and accessibility of so much of mental health care in America. And then we're glad to have Dr. Jeff Rideout, the President and CEO of the Integrated Healthcare Association. He's recognized for his work in provider data management utility. That's a mouthful, but in plain old English, it makes sure that there's a focus on, particularly now where there's so much content out, making sure it's presented in an intelligible way, and we appreciate it. Glad you're here. Let's begin with you, Ms. Myrick.
Thank you. Chair Wyden, Ranking Member Crapo, and members of the Senate Finance Committee, thank you for conducting this hearing today and providing me the honor of testifying regarding ghost networks and provider directories. My name is Karis Myrick, and I'm Vice President of Partnerships for Inseparable, a nonprofit working to advance policy that reflects the belief that the health of our minds and our bodies is inseparable. I'm also a mental health advocate and survivor with lived experience of ghost networks and health plans. I'm here today to share my story and bring attention to this very critical issue. Ghost networks erect invisible, unexpected barriers within our health systems, preventing people from accessing the care and support that they need. They are particularly damaging for those of us living with serious mental health conditions like me, as they can result in delayed or inadequate treatment or even going without, any of which can be devastating and have devastating consequences. My first experience with ghost networks occurred when I had to change my health insurance due to a new position with the federal government in 2014. Navigating the Blue Cross Blue Shield for federal employees provider directory to find a psychiatrist in the DC or Maryland area turned into one rejection after another. Call after call resulted in the following types of responses. Who? She doesn't work here. No, I don't know where they are. Who? I don't know who that is. Not sure they ever worked here. Hold, please. Dial tone. Or a recorded message. Dr. Fill in the blank is no longer accepting new patients. If this is an emergency, hang up and dial 911. I spent countless days and hours scouring the networks and finally found a psychiatrist who was taking new patients. Success, though, was short-lived. In a call to set up an appointment, I was asked about my diagnosis, and I responded without any hesitation, schizophrenia. A pause, a long silence, and then the response, oh, I don't take patients with schizophrenia. I asked if they have any suggestions or referrals to help me find a doctor who does. And the answer is, check the provider directory. Going back to the directory was like looking for a needle in a haystack. Lots of hay, very few needles, and none that can stitch together the needs of my schizophrenia garment. Finally, I contacted my psychiatrist back in California and asked if and how he could remain my doctor. I ended up flying regularly to Los Angeles at my own expense for over a 4-year period to ensure that I could be and stay well. I also paid high out-of-network copays, but at least I had a provider. On the same plan, when I needed a doctor for what turned out to be thyroid cancer, I was able to find an endocrinologist the very same day. But for mental health, it was a very different story, a story that continued throughout my career. In 2018, I began working for the Los Angeles County Department of Mental Health. My LA-based psychiatrist now was my colleague, so I had to find another psychiatrist. I searched the provider directory with trepidation and received dead-end responses. In 2020 and 2022, I dealt with new insurance plans and new provider directories. Each time, it felt like the movie Groundhog Day, with the all-too-familiar responses. There's no provider here, no one by that name, oh, they're retired, or they aren't taking new patients. There's literally no there there. Unfortunately, my story is not unique. Many of my peers with mental health diagnoses face similar challenges, regardless of whether they are covered by Medicare, Medicaid, or private insurance. Even today, despite having health insurance that is otherwise considered excellent, I have no regular psychiatrist. This leaves me with ongoing anxiety about what will happen if I should need more intensive or ongoing care. I have experienced being unhoused, unemployed, having interactions with the criminal justice system, and involuntary hospitalizations. I don't ever want to go through those traumatizing experiences again because I wasn't able to find a provider through my health plan's directory and get the help I need to stay well. I don't have to worry about this for my thyroid condition. I have a specialist, an endocrinologist, readily available under every insurance plan. Why then do I not have the same for my mental health? Senator Wyden, you had said, too often Americans who need affordable mental health care hit a dead end when they try to find a provider that's covered by their insurance. Ghost networks means that the list of mental health providers in insurance company directories are almost useless. Never a truer word. As a survivor with lived experience of ghost networks and health plans, I urge the committee to act on this critical issue through policies, and I have 3 recommendations. 1, provide the oversight, enforcement, and incentives necessary to result in highly accurate provider directories. 2, require the inclusion of psychiatric subspecialties in directories. And 3, implement a federally operated mechanism like online reporting system or dedicated 1-800 number for consumers and plan members to report their experiences of ghost networks and to use that information to enforce policy and inform policy and enforcement actions. So thank you again for the opportunity to share my story today. Mr. Chair and members of the committee, I would be happy to answer any questions that you may have for me at this time.
I think it is very clear you're going to get plenty of questions, Ms. Myrick, and we thank you very much for being here. Let's go to Dr. Resnick.
Chairman Wyden, Ranking Member Crapo, thank you for the invitation to participate in this hearing. I'm Jack Resnick, President of the American Medical Association. I'm a practicing physician and chair of the Department of Dermatology at the University of California, San Francisco. You know, as you said, physician and provider directories are critically important tools. They help patients shop for and select insurance products that cover physicians who are already part of their healthcare team and find in-network care that they need once they're covered. They help physicians make referrals for our patients, and they serve as a representation of a plan's network adequacy for regulators. So when directory information is incorrect, the results are costly and devastating for patients, as you heard from Ms. Myrick and her lived experience. You know, at a time when our nation is fighting a mental and behavioral health crisis, inaccurate directories are not only an absolutely infuriating barrier for patients and families already in great periods of stress, who must waste time calling practice after practice to find one that is actually in network and accepting new patients, but they help mask the fact that insurers consistently and frankly egregiously fail to provide adequate networks and comply with parity laws, causing harm to millions of Americans. And the problem is not limited to mental health. You know, not only have I read the many studies showing the scope of problems with provider directories, but I conducted one of these studies myself, so this hearing is of particular interest to me. A few years ago, I had med students call every dermatologist listed in directories for many of the largest MA plans in a dozen U.S. metropolitan areas. They sought appointments for a fictitious patient with a severe rash, and the results were dismal. Of 4,754 listings, almost half represented duplicates. Among the remaining listings, many of those practices didn't exist, had never heard of the listed physician, or reported that they had died, retired, or moved away. Others were not accepting new patients or were the wrong subspecialty altogether. So in the end, just 27% of listings were unique, accepted the listed plan, and offered an appointment. And sadly, more recent studies, including your own, Mr. Chairman, demonstrate that these problems persist and maybe even are worsening. Achieving directory accuracy, it's not simple, and I acknowledge that physician practices do have a role to play, but the responsibility of directory accuracy ultimately lies with the plans. Being listed correctly in a directory is a fundamental component of a physician health plan contract, and health plans are not making it easy for physicians to help. I work at a pretty big academic medical center. You'd think our big staff devoted to this work would equate to more accurate listings. But health plans are typically taking 6 to 8 months to add or delete physicians after we notify them of changes. They don't use standardized formats, so we have to send different rosters with different formatting to each and every one. For big and small practices, typically contracting with 20 or more plans, this amounts to a costly and just demoralizing administrative burden. And it's happening at a time when the physician workforce, emerging from the pandemic with skyrocketing levels of burnout, is facing a web of growing and wasteful obstacles from these same health plans, obstacles like prior authorization. My physician colleagues, they need to be freed up to spend time doing what drew us all to medicine in the first place, taking great care of our patients. So what are some solutions? Well, first, in 2021, the AMA collaborated with CAQH to examine the pain points for both physicians and health plans in achieving directory accuracy. And I'm here to urge all organizations charged with regulating health plans to take a more active role in regularly reviewing and assessing the accuracy of directories. For example, regulators should require health plans to submit accurate directories every year. That's what patients deserve. Audit directory accuracy more frequently. Take enforcement action against plans that fail to maintain complete and accurate directories with monetary penalties. Encourage stakeholders to develop common standards for updating physician information in their directories so practices like mine don't have 20 different methods, and require plans to immediately remove physicians who no longer participate in their network. My study was in 2014, and here we are today. Enough is enough. We can fix this. Moreover, I urge policymakers to continue to examine the issues that phantom networks and inaccurate directories may be masking. Problems like overall workforce shortages, a lack of network adequacy, and plans' rampant failures to adhere to mental health parity laws. Thank you so much for considering my comments. Happy to take questions, and I'm looking forward to the discussion later.
Great.
Thank you.
Dr. Trustman.
Chairman Wyden, Ranking Member Crapo, and members of the Senate Finance Committee. On behalf of the American Psychiatric Association, I really want to thank you for conducting this hearing and for all of the work you've been doing in this domain. We greatly appreciate your continuing bipartisan efforts to confront the mental health and substance use crises in our country. And we're grateful for the opportunity to give testimony today. Ghost networks affect private sector health plans purchased by individuals and employers, and public plans like Medicaid and Medicare Advantage. My written testimony references data from several studies about the ubiquitous nature of directory inaccuracies. These include, as we've already heard, misrepresentations that clinicians are accepting new patients, wrong phone numbers, and even listings for clinicians who are no longer in the state. But I'd like to speak to you about my personal experience with how phantom networks affect our patients, burden physicians and other providers, and increase costs. My department at Carilion Clinic is in rural Virginia. We deliver over 90,000 care visits per year to individuals living with a broad range of complex mental illnesses and substance use disorders. Access to care in rural settings, like mine, is particularly challenging. These areas are generally physician shortage areas to begin with, and patients can be required to travel for hours to find psychiatric care. Finding anyone who is accepting new patients can be nearly impossible. Carilion Clinic is the region's only tertiary center, and we function as the public health point of access for so many people. My clinic is in almost all networks, and our waiting list for patients currently numbers over 800 people. For those who are healthy and well-educated, going through an inaccurate provider list and being told repeatedly that we're not taking new patients, this provider is retired, we no longer accept your insurance, or leaving a message that no one returns is frustrating. But for people experiencing significant mental illness or substance use disorders, the process at best is demoralizing. and at worst is a setup for clinical deterioration and a preventable crisis. Many are already experiencing profound feelings of worthlessness, grief from loss and trauma, and or the impact of substance use. Patients have shared with me that they felt themselves repeatedly rejected and that somehow the fact that they couldn't find a provider was their fault. Some give up looking for care. At Carillion, keeping our credentialing updated with insurance plans is time-consuming and expensive. We have multiple full-time employees doing nothing but maintaining our credentialing with insurance companies and public payers, including Medicaid and Medicare Advantage. This is a burden insurance companies, I believe, should bear, not those of us trying to provide desperately needed care. The national administrative burden for physician practices to send directory updates to insurers through disparate technologies, schedules, and formats is $2.76 billion annually. Not all mental health clinicians practice in settings like mine that are willing and able to invest the resources needed to participate in the networks. Private practitioners make up a significant portion of the psychiatric workforce, and many do not participate in the networks because of the administrative burden. Ghost networks are both a cause and a symptom of a system that has shortchanged mental health care for decades. We need the help of Congress to change that. My written testimony includes recommendations that we ask the committee to consider, many of which you're already pursuing. It's time to hold plans accountable for maintaining accurate directories and making accurate representations to patients, to clinicians, and to employers. Our patients also need public and private sector plans to be held accountable to the mental health parity law. Further investment in expanding the mental health workforce, particularly in underserved areas, is vital. Our Congress might further incentivize the adoption of models of integrated care, like the collaborative care model, that improves outcomes and expands access while furthering the support of our primary care physicians in their ability to deliver a lot of the care. Thank you for the opportunity to testify. I look forward to your questions.
Great. Thank you, Doctor. Ms. Giliberti.
Chair Wyden, Ranking Member Crapo, and members of the Senate Finance Committee, thank you for the opportunity to testify today regarding provider directory inaccuracies and ghost networks, issues that my organization has been working on for over a decade and that cause great harm. My name is Mary Giliberti, and I lead the public policy efforts for Mental Health America. My written testimony details my experiences helping friends, families, and community members access mental health providers. The very first question I ask them is, do you need these services covered by insurance? I ask that question because I know it's going to be quicker and less effort if they can pay out of pocket, but so much more expensive. For example, I was helping one young woman who, like many others, found that her mental health condition was deteriorating during COVID, and her therapist recommended that she seek medication. Not surprisingly, she wanted to pay a minimal copay and not hundreds of dollars each visit. So I helped her make a list of recommended psychiatrists that were on her directory. And by now, you've heard the story many times. She started making calls. Some didn't call her back. Others told her they were not on her network, even though they were in her directory. Weeks went by, and her condition only worsened. Fortunately, somebody at work knew of a telehealth option in her plan, and she was able to get in-network care, but only after a very painful delay. Some people, as was noted, give up entirely after making these unsuccessful calls. When you're experiencing symptoms like lack of motivation, anxiety, and psychosis, and you're getting worse, you are least able to navigate these inaccurate directories. And these are not just anecdotes. They're supported by many studies. And unfortunately, Chair Wyden, your state didn't do very well in this study either of Medicaid managed care programs. Using claims data, researchers found that 2/3 of the mental health prescribers listed in the plan directories were phantoms who were not billing the plan. 2/3. Reviews of Medicare Advantage plans also show high levels of inaccuracies. So what can be done? We know from studies of state statutes, it is not enough to just require accurate directories. That's been done, and over this past decades has not worked. We have 3 recommendations for policy change. First, the data must be verified by a reliable method, such as an independent audit and claims data. At nonprofit organizations like mine, we can't just submit our financial data. We have to have it audited by somebody. Last week, CMS issued a proposed Medicaid managed care access rule requiring states to use secret shopper surveys by an independent entity. The surveys would determine the accuracy of directories and wait times for mental health and substance use services, among others. This policy is an important step forward, should be finalized, but CMS also needs to require audits of Medicare Advantage plans through its own review and those of independent entities. Plans also should be required to use their claims data to periodically reconcile these directories. With the workforce shortages we have, if they're not seeing somebody, we know that if they're not filing claims, they're not seeing people, they're not in the directory. Second, the information should be transparent. In other areas of healthcare, CMS requires transparency. This area needs more sunlight. The proposed Medicaid rule requires secret shopper information to be posted on a state website. That should be very easily understood by consumers and regulators, and we should have that kind of transparency across all plans regulated by CMS so we can see what's going on by plan, not in the aggregate, but by plan. Third, and most importantly, plans have to be fiscally incentivized to provide accurate directories. This requires carrots and sticks. On the carrot side, we can incorporate accuracy rates into overall quality ratings that affect which plans consumers choose and bonus payments like the star rating system. It's important that the plans that are doing well are rewarded for doing well. Then we should have penalties for those that are not doing so well, similar to HIPAA's enforcement provisions with compliance reviews, clear benchmarks, and civil monetary penalties that are enough to change behavior. An individual should always have financial protection if they rely on an inaccurate directory. In my written testimony, I reference related areas that would also affect directories, including reimbursement rates, integrated care, telehealth flexibilities, and expanding parity coverage to Medicare Advantage and Medicaid and Medicare fee-for-service. In conclusion, there will always be some provider directory inaccuracies, but the high rates consistently revealed in recent studies are not minimal errors. They are consumer and government deception, misrepresenting the value of the plan, undermining consumer choice, and causing great suffering. With the right verification of data, transparency requirements, and fiscal incentives, we can do so much better. Thank you, and I look forward to your questions.
Thank you, Ms. Giliberti. You will have questions, for sure. Dr. Rideout.
Good morning, Chairman Wyden, Ranking Member Crapo, and members of the committee. Thank you for inviting me here today. I'm Dr. Jeff Rideout, President and CEO of the Integrated Healthcare Association, a California leadership group whose members include physician groups, health plans, hospital systems, regulatory agencies, and other healthcare stakeholders. Among our many programs, IHA manages a California-wide provider data management program called Symphony, which is the focus of my remarks today. The issue of provider information accuracy is of great professional concern to me. Prior to joining IHA, I was the first senior medical advisor at Covered California, our state's insurance exchange, overseeing the launch and shortly following the wind down of its first online provider directory. So I'm very familiar with the challenges in creating accurate provider information. The problem is real and pervasive. The key question is how to solve for it. The accuracy challenges that were exposed in that early Covered California effort led to new regulatory requirements in California through Senate Bill 137. It also led to a comprehensive industry effort to address the longstanding challenges in provider data accuracy, which became the Symphony program. Symphony's goal is to simplify and unify how providers and health plans share, reconcile, and validate provider directory information. With our technology partner Availity, we are creating a single utility designed to be the primary source of information, which will replace existing and non-aligned processes between health plans and providers. As an output of the process, Symphony creates a golden record by applying a strict set of agreed-upon rules that determine what the best information is when the information from multiple organizations is conflicting. It is a form of machine learning. The more organizations, the greater the likelihood of finding errors before this information goes back to the plans and providers for inclusion in their directories. Symphony now has 17 contracted health plans, more than 100 contracted provider organizations, and is also engaged with Covered California. In fact, participation in Symphony is a Covered California contractual requirement for all participating plans. Symphony currently maintains over 170,000 unique provider records and supports more than 300 data elements, such as license verification and accepting new patients. Ultimately, sustainable provider data improvement requires a collaborative solution. The Centers for Medicare and Medicaid Services said it best in a 2018 report, quote, "It has become clear that a centralized repository for provider data is a key component missing from the accurate provider directory equation," end quote. Symphony is exactly that type of centralized repository. What have we learned so far? Provider data encompasses literally hundreds of specific data elements, and most need to be verified on a very frequent basis. We need more. We need more data elements related to LGBT support. We need more data elements related to race and ethnicity. So this problem of the data elements will just grow, not shrink. In addition to the data itself, providers need to attest to the accuracy of the information every 90 days or sooner. Under these conditions, providers are much more willing to do so if they can attest once for multiple plans. Understand it is the provider data that is ultimately populating a provider directory, and it's the ultimate source of accuracy. Based on the number of different data elements, all Symphony stakeholders now have agreed to prioritize the data elements most important to consumers, such as accepting new patients. Symphony is a dynamic process that continues to adapt. Before Symphony could even get started processing data, we had to first create standards that conform with regulatory requirements. These include standards for timeliness, data quality and completeness, and data accuracy. Critically, these are the same across multiple plans and provider organizations. This allows Symphony to apply a mastering process to identify inconsistencies and resolve them. Identifying inaccuracies and correcting them is necessary, and it is feasible. In the last 30-day period for Symphony, provider data from 169,000 unique providers identified over 138,000 inconsistent data elements, which we call updates or corrections, that require health plan and provider changes. Of these, 5,000 were errors in physical office address, which is an access issue, while nearly 2,200 were related to license issues. And we do this every 90 days. Improving provider data accuracy is a complex undertaking. For independent providers, of which mental health providers are more likely to be, this can be cost prohibitive. Without a centralized data repository that supports a multi-plan provider directory, health plans and providers will be unable to maintain accurate provider data and directories individually, even with the best of intentions. This is critical for mental and behavioral health providers who are increasingly less likely to be in health plan networks, making it even more critical for them to be able to update their data in a convenient, single, centralized repository. Thank you for your attention.
Thank you very much. Ms. Myrick, I was listening to your eloquent statement, and I was saying to myself, what is it like in America when someone like you, who is in the Obama administration, who specializes in healthcare, gets bounced around the mental health system the way you described? I just kept thinking to myself, what's it like for the typical person in the typical family if they go through what you described? And I think the question I have for you, because I think you're exhibit A for why we so desperately need reform, what's going to be the consequence of doing nothing? What if the insurance companies just to keep doing business as usual? What are going to be the consequences? Because it seems to me the problem you described, intersecting with the tremendous increase in demand, is a big problem for the country. So just, if you would, paint the picture of what happens if we don't do the kinds of reforms that you and your colleagues are talking about.
Thank you for the question. I don't know that I'm a soothsayer, but I think, if I think about the consequences, it's much of what I talked about in my testimony, that, if you're going without health care and you're going without mental health care, the consequences are dire, and we see them in our statistics related to people with mental health conditions who become unhoused, who are criminalized, who end their own lives. So really, I think the consequences at the end of the day are about the difference between life and death. And that's pretty dire.
We may have to put you in charge of the federal government. By the way, when
No,
you were
thank you.
making those comments, yes, right, you want to be in California. When you were making those comments, your colleagues, particularly the physicians on the panel, everybody's nodding, so thank you for that. Let me go to you, Ms. Giliberti, with respect to the financial burden of these ghost networks. As I mentioned, the Finance Committee felt like a gazillion calls, but 120 looked for an appointment for a senior with depression. The vast majority of cases, the vast majority, be one thing if it was incidental, resulted in a dead-end phone call. We were able to make an appointment 18% of the time after hours and hours on the phone. And the reason I wanted to talk to you, because it reminded me a little bit of my Gray Panther experiences, what you were talking about, and kind of crunching some of the numbers. For some patients who were able to make an appointment, they found out that the provider they saw, who was listed in their plan's directory, was actually out of network. So the patient gets stuck with the bill. Now, why should the patient be on the hook here? The insurance company is not doing what they purported to do when they were taking the consumer's money. And yet the patient, in what you've been describing and others who are advocating for consumers, seems to me actually backwards. Is the insurance company hasn't done what they indicated that they would do, but it's the patient who's on the hook when they desperately need coverage and they have to reach out of network. What should the committee do in a situation like this? My friend Senator Crapo has always been so constructive on this. We work in a bipartisan way. So when we see a problem, we say, hey, where's the common ground we can get Democrats and Republicans to be for? What is that kind of common ground here so that we can actually help that patient who, in my view, is just being fleeced? That's what we used to say it back when I was co-director of the Gray Panthers.
Right.
We didn't talk health lingo. We said this person's just being fleeced. But now we got to figure out how to navigate reforms. What kind of reforms should Senator Crapo and I pursue here?
Well, first of all,
With our colleagues.
It should not be the responsibility of the individual, right? In my view, they should be compensated for the stress that comes when you get a bill like that. You open the paper and it's like, hundreds of dollars. You expect a $25 copay and you're looking at hundreds of dollars. They should compensate you for that stress. And instead, you're expected to pay that. So if the directory is inaccurate, the consumer should pay in-network prices. So their regular old copay. And the plan should have to cover the rest of that cost because their directory was inaccurate. So it should not fall on the person who's least able to bear this cost, right? I mean, if you think about these companies, who's in the best position to bear the cost? The individual or the company for the mistake that was made? And they represent this network. That's part of what you're paying for, right? I mean, when you choose that plan, when a consumer goes to the website, they choose a Medicare Advantage plan, and that's one of the advantages, right? They can pick one. But they pick based on what they see, and then if it's not accurate, that shouldn't be their problem. They shouldn't have to pay for that.
I'm over my time. Thank you all. The panel's been excellent. Senator Crapo.
Thank you, Senator Wyden. And Dr. Rideout, I'd like to start with you, and I'm going to ask a question similar to the one that Senator Wyden just asked Ms. Giliberti. And that is, well, first of all, thank you for the work that you've done on the ground in terms of helping to improve the accuracy of provider directories. You talked about a lot of important things in your testimony. If you could just summarize for us, what are some of the key practices that we need to be focusing on here as the solution? Bring it down to some of the best.
Well, I think you've highlighted several of them, transparency being one, better auditing being another, potentially penalties being another. My concern would be if this is done without sort of an on-the-ground operational solution, you will double down on bad practices. We will get more intensity from health plans to avoid penalties. We'll get more suppression of networks potentially. We will get more urgency and challenges for the physicians and other providers who can't afford and are really being distracted from what they're doing. So I think ultimately having a single source of truth, however that's organized, whether by state or nationally, gives everybody a fighting chance to say this problem is about intentions, or it is about accuracy, or it's a combination of both. So I would say it's hard work, but you've got to kind of get that part fixed as well, or else we'll just double down on what's happening now.
Well, thank you. And Dr. Resnick, again, following up on the same thing, you mentioned in your testimony that the physicians are facing a crisis here themselves trying to deal with this solution, and we're seeing a lot of unprecedented stress and burnout exacerbated by administrative burdens. We don't want another government program or another government mandate that just puts burdens on everybody and doesn't get to the solution. What could you do if you could just concisely bring it down to what are some of the best things we should consider here to achieve this objective without causing the damage that could be caused?
We appreciate your leadership on this and the bipartisan engagement. There are some things we think you can do. And while there are some excess regulations we'd love to talk about in another hearing to reduce, this is one area where we actually need congressional help. And I think there are some straightforward things. We hear from HHS that they don't think they have the tools to audit and enforce and impose monetary penalties on the MA plans and the exchange plans that they have oversight of. I know it may not be in this committee's jurisdiction, but the Department of Labor needs additional authority around ERISA plans. And then we at the American Medical Association are putting in a lot of work with our colleagues in state medical associations and specialty societies, going to states to make sure that insurance commissioners also at the state level have increased authority. If we don't have monetary penalties on these plans for continuing to put out these fake networks to make these fake directories to make their networks look bigger than they are, we're not going to make progress.
Well, thank you. And Dr. Trestman, according to the National Institutes of Health, Americans in rural communities, as you indicated in your testimony, experience a significant disparity in mental health outcomes, even though the rates of mental illness are consistent in rural and metropolitan areas. Over the course of the past two Congresses, we've explored how different problems within our mental health care system disproportionately impact rural communities. Could you just tell us from your experience in practicing psychiatry in a rural community, how do inaccurate provider directories and other access issues impact these areas differently than metropolitan areas?
Thank you, Senator. I think many of the issues are identical. The challenge is the provider directories are even more sparse for us, and the geography is really challenging. The challenges that our patients have faced have driven us to many limited resolutions. Oftentimes, their primary care physicians have been tasked to take care of the psychiatric issues because there's no one else available. Helping us to empower them is really critical as well. So I think that telehealth has been another extraordinary advantage for people with broadband access and the ability to afford data plans. They have telehealth with video, which is wonderful. But in many rural areas, including mine, this last week, I did some of my visits by audio only because that's all that was available.
Right.
Thank you.
Thank you very much.
Very important point. Senator Crapo and I, during our telehealth discussion, we heard consistently from rural communities that they support broadband, but if they don't have it, they want audio only. Senator Cornyn's next.
Thank you, Mr. Chairman, for this hearing today. Thanks to all the witnesses. This is a disturbing issue of ghost networks. I want to ask, though, that there's a bill that Senator Cortez Masto and I have introduced, and Dr. Trestman, you happen to mention this in your written testimony, the Complete Care Act. I know the nature of practicing medicine has evolved a lot, probably during your professional career, both yours and Dr. Resnick's. But one of the things that seems to make a lot of sense to me is we now are embracing the whole person and not just dealing with physical health, but mental health too, to find ways to integrate mental health into physician practices. Could you share more about how you think the bill might be able to help, Dr. Trustman?
Absolutely, and thank you so much for your work on this. You know, as I understand the bill, the opportunity is with the partnership between primary care and psychiatry. The challenge that we've seen over the years, and I worked closely with our colleagues who developed the collaborative care model at the University of Washington. I've worked with people around the country, and I've tried to implement the collaborative care model in my own health system. It's challenging, and frankly, the challenge isn't so much on the side of psychiatry. The challenge is on the side of primary care. It's hard to change workflows. It's hard to have an integration and support system. So I think that the complete proposal that you and Senator, forgive me.
Cortez Masto.
Cortez Masto have developed is critical because it front loads reimbursement and support for primary care to make this real for the first few years. That's central and a wonderful opportunity.
Well, we look forward to working with you and others on that. I know the chairman and ranking member have talked about things that the Congress has done recently in the mental health area, and certainly I agree with them that the status quo is completely unacceptable. We've failed to provide that mental health safety net. But one of the things that I would just draw your attention to or refresh your memory on is we passed the Bipartisan Safer Communities Act last year. It was Senator Tillis and I were involved in hot and heavy negotiations with Senator Sinema and Senator Murphy on this after the terrible shooting in Uvalde. But one of the most overlooked aspects of that, I think, happens to be one of the most important aspects of it. That is expanding the certified community behavioral health clinics and the funding for that. As you know, there's been a pilot program. Senator Stabenow and Senator Blunt had been taking the leadership on that for many years, and I congratulate them for that. They've really led the way. But we made, I think, the single largest investment in mental health delivery in American history, which is incredible and great. But here's the challenge. Dr. Resnick, where are we going to find the workforce? Where are we going to find the trained physicians, psychologists, counselors, and the like?
It's a great question, and I'm glad you brought it up, Senator. As you all probably know, and we've talked with all of you about over the years, and many of you have led in this area, we have a graduate medical education crisis in the United States as well, and psychiatry is a part of it, but it's really across all specialties where we are now seeing shortages. Patients are facing long wait times. I think about this in a few ways. So there's the front end, as you mentioned, training more physicians and non-physician clinicians and nurses, et cetera. We need more GME dollars. We need support for that big bill that will help to accomplish that. Training physicians does take a while. We need immigration reform and additional resources for the Conrad 30 program to help to grow that as well. That provides critical physician access in cities around the country. I also think about workforce at sort of the tail end of the pipeline. I'm worried because as I look at my colleagues around the country, these soaring rates of burnout the last few years, and we know all the things that contribute to that. But if we continue to have health plans adding burdens to physicians, whether it's prior auth, whether it's inaccurate directories, we've got 1 in 5 physicians telling us that they're likely to retire in the next 2 years. So we could acutely lose a lot of that workforce too. So it's important that we think both about the sort of training end and about getting those obstacles and burdens out of the way so we retain the workforce we have.
Thank you. And of course, that applies, as you indicated, not just to physicians, but to allied health care professionals and even school counselors, where part of the problem that we made an investment in safer schools, too, because that's where most of the mental health problems, I believe, are likely to be identified and then referred for the kind of care that these kids need in order to get well and not get sicker and sicker and be a danger to themselves and perhaps others. Thank you, Mr. Chairman.
I thank my colleague, and my colleague who spent a lot of time on these mental health issues and with Senator Stabenow has been doing some good work, is making a very important point, and that is we've got a big challenge ahead of us, some serious lifting with respect to workforce, and that's why Senator Crapo and I so appreciated the chance to work with the two of you, Senator Stabenow and yourself, on those workforce issues. And the fact is, in the gun safety bill, the reason we were able to get it in was we had taken the time to write black letter law, and we were ready to go, and the two of you spearheaded the effort. We were going to build on it. I do want to make sure that apropos of my approach to this is I'm going to be all in on these workforce issues, but that is not the same thing as running a ghost network, which is misrepresentation. So we got to deal with both of these issues, and I look forward to working with my colleagues in a bipartisan way on both of these questions. Senator Grassley is next.
Well, can you skip me?
Of course.
There's no way to skip to, right?
No, we got plenty of people.
And then get me on the next.
What we'll do, because Senator Grassley has strong views on these issues, we will have Senator Tillis now and then Senator Stabenow. And if other colleagues are on the way, let's get Senator Tillis and Senator Stabenow and Senator Grassley in, and then I hope other colleagues will come. Senator Tillis.
Thank you, Mr. Chair. Thank you all for being here. I'm glad that Senator Cornyn brought up the Safer Communities Act. People call it a gun safety bill. I call it a mental health and safer communities bill because it is an extraordinary investment. And proud that North Carolina is one of the first 10 states to receive the tranche of funding to expand behavioral health access, particularly in rural communities, but across the board. Ms. Myrick, back in 2007, I was diagnosed with an illness that required me to take medications that caused me to have pharmacologically induced mania, followed by clinical depression. So I got a window into mental health that I consider to be a blessing. Had I not had a wife, when I'm in mania, I felt like I could fix any problem anyway. I simply would not have sought a healthcare or a behavioral health professional. And when I was in depression, if I went to a website, went through what you did, I'd have said, what's the use? So we need to understand this has real life consequences, and you're in the worst possible state to have the complexity and maybe even have it in the middle of depression, finding out that you have to pay out network costs. So now you've got financial stressors, you've got whatever the underlying condition is. The insurers, the providers, everybody need to understand that. I want to get to getting regulations right. I think if we're punitive, then the resources to the healthcare, to the insurers is going to come from somewhere. And most likely it's going to come from the pockets of patients at the end of the day or from providers by lower provider rates. So we have to get this right, but we have to do something. And I'm sorry, how do you pronounce your last name?
It's Rideout.
No, I'm sorry, I got yours.
Giliberti.
Giliberti, okay. What would be wrong with HHS and CMS? I work for a Big Four audit and management consulting firm for most of my professional career. And for one thing, it's shocking to me that the insurers wouldn't have this as part of their annual audit regimen, that they already don't have within their all of them have internal audits. They have the scale, they have to have it, and compliance. It's shocking to me that they don't have an audit program of record where they're going through their provider networks. So rather than mandating that, why couldn't we move towards mandating to CMS and giving CMS the technology, the resources necessary to do it, that we're going to perform audits. We're going to determine, I think in one example of Medicare provider information, that they're about 50% accurate. What would be wrong with an audit or a review by CMS giving them an F because they have a failing grade and having published that on the website? A part of the carrot, and I think a competitive advantage for the insurers would be go to the CMS website, see our rating. We've got an A, B, C grade, 1-star, 2-star, but why not a kind of an incentive for them to just make this a part of standard operating procedure, auditing it, and then getting the underlying information systems that they have in place to get a higher grade. Rather than, because if we come down with a heavy hammer they're going to comply. But that's also taken their attention away from finding additional providers, driving down cost of insurance, and a number of other things. What would be wrong with a light regulatory regimen as a way to start that I think that generally would get bipartisan support?
Well, I think that that is absolutely an important component, so it would be a great advance forward.
Yep.
You know, obviously, we'd like the whole piece, but I think that having that would be very, very helpful. CMS has done some auditing, but they didn't identify the plans, which I think is what you're saying,
Yeah.
Senator.
Well, and I think if you do that, you're going to find the audit and a test ecosystem very quickly come up with advisory services that are going to go after these companies and figure out how they can accelerate it, get
Well, and
data
you can
integrity right, get out of the over-promising and under-delivering that we have today. And I also think you said something that's very important. If you have somebody select a plan, maybe because they looked and saw a very large provider network, and that proves not to be the case, and they have to go out of network, I think that's a legitimate case where the person who sold you the expectation that you had these options, and when you came into crisis, you have those, that should be the insurer's problem, not the insured, the insurer's problem. But to me, those are relatively modest changes that, if they're implemented properly, I think could have a significant behavioral impact that benefits the insurer. And I have no more time left, but on the workforce thing, if we want to get this right, it can't be just about educating more doctors, because we simply won't get the pipeline. I spend a lot of time, I've got a couple of schools you may have heard of, Duke, Chapel Hill, they train a lot of doctors. They tell me that the outlook is bleak. So if we knock the cover off the ball, we're still not going to have enough. And we're not going to knock the cover off the ball of getting people into this profession if we don't deal with a number of other underlying reasons why people are leaving earlier and not getting into the profession.
Thank you, Senator
So
Phillips.
those are things we have to talk about if we're seriously going to get it done. Thank you, Mr.
We're
Chair.
going to work with you. Senator Grassley.
I'm ready now. I'm a strong supporter of telehealth, and when I was Finance Committee Chairman, I helped make it a permanent in Medicare. Several states have followed suit in their Medicaid program. While I supported making telehealth permanent for all services, mental telehealth is an important tool to improve access, especially in rural America. So I'm going to give one question to Ms. Giliberti and another question to Dr. Trestman. The question, I'm going to state both of these now. Ms. Giliberti, in your written testimony, you said nearly half of the adults and youth with mental health needs don't receive treatment. Access to care can have many challenges. Has telehealth and investments in broadband helped improve the access issue? And for Mr. Trestman, in your written testimony, you said access to care in rural settings is challenging. You specifically highlighted how telehealth improves access to more timely care. Given the recent expansion of telehealth, are patients getting the best mental health care? And if not, what can we do to improve the quality of care? Mrs. Giliberti?
Yes, Senator, absolutely. Telehealth has had a tremendous effect on access. In fact, the story that I told, the young woman actually finally got care using telehealth. So it has disproportionately affected the mental health community. You want to have access to in-person as well, but having telehealth, particularly in rural areas, has definitely been a game changer. We need to extend those flexibilities and make them permanent. We also need to worry about licensing between states, because that becomes a problem as the emergency ends.
Yeah. Dr. Trestman.
Senator, thank you, and thank you for your work in this issue. It is enormously challenging, and as Ms. Giliberti had said, the benefits of telehealth during the pandemic have been demonstrated. They are substantial. Many people are in rural areas simply unable to meaningfully come to us without telehealth, without taking off days of work. Many don't have paid medical leave. They lose a lot of money coming to see us. The opportunity with telehealth is really substantial in providing appropriate care. The data is still evolving as to who is best served in person, who is adequately or appropriately served by video, and who is adequately served by audio only in what conditions. But in my own experience, and I still see a lot of patients, I have had insights into people's lives by seeing them in their homes that I otherwise never would have gotten if they traveled to me. So I've had opportunities that have benefited both me as the doctor as well as our patients by having access to them in a timely way, in a way that doesn't put additional burdens of cost and time on them, and that allows me to see them in the environment in which they live. Thank you.
Yeah. I've heard from Iowans about the challenges finding in-network providers, including mental health services. There are many reasons for the bad provider directories. Even the best information may not be user-friendly. Patients may have to navigate pages and pages of information. For any of you witnesses that want to comment on this question, are government regulations or incentives preventing the private sector from solving this problem? And I don't care which one of you or two of you comment on it. Okay?
I would say the lack of standardization is a problem. So, and several panel members discussed this. The fact that a provider may have to, whether it's a physician provider, mental health provider of any type, may have to deal with literally dozens of health plan requirements that come at them, different elements, different times, different submission standards, different expectations, and then have to repeat that over and over again every time something is potentially wrong. It's just a burden that they can't absorb, even the largest organizations, and that's what we see in our work. We have to fix the accuracy problem together.
Thank you, Senator Grassley. We have to call a lot of audibles around here, and because of Senator Casey's graciousness, Senator Stabenow will go next.
Well, thank you so much, and thank you to all of you. This is so important that we actually have accurate provider directories, and this is just part of the whole big picture. I remember back in this committee when we were writing the Affordable Care Act, and I authored the provisions on mental health parity, and we're still finding this. And I mean, it's in every way, we are coming back all the time. Healthcare above the neck not being treated as well as healthcare below the neck. And Ms. Meyer, thank you for your testimony and sharing with us. I'm sorry you had to go through all of this. I do want to expand a couple of things, because I'm all in, Mr. Chairman, on what you want to do, absolutely all in. I do want to stress, as Senator Cornyn was talking about, that we have made progress. And frankly, one of the alternatives, I would love, Ms. Mike, for you to be able to contact your local certified community behavioral health clinic. They're in areas now where we have them fully funded. They're funded like healthcare. You can walk in the door. A third of the time in Michigan, one of the 10 states where we're fully funding it, a third of the time people are seen immediately. And people are seen within 10 days and required, and there's a whole bunch of things there. But we have 10 more states coming on at the beginning of the year. We're moving to get all the states engaged. Largest investment in permanent mental health funding ever for the country that is coming. And so step by step by step, this is part of the answer. It's not the whole answer. But you know, if they want to put up ghost registries, go to your CCBHC and we'll get you some care. And so, as a start. But I want to talk, and certainly we can come back to that, but I wanted to follow up also on the issue of providers, because we have the provider networks, we have these ghost lists, and then we just don't have enough providers. Right, and we know this, and one of the things I so appreciated that we worked on last year, Senator Daines and I, as co-chair of a workforce working group that Senator Wyden and Senator Crapo set up, a really important part of our mental health work. We actually did a few things, but there's more things to do. We were able to get a small number of graduate medical education slots, 200 slots, and half of those for psychiatrists. Small, but first time we designated psychiatric slots, and so that was something. We were able to get Medicare coverage for licensed professional counselors and marriage and family therapists. But I wanted to ask Ms. Giliberti, one of the things that Senator Barrasso and I have introduced, and it's been around for a long time, relates to social workers. And we have the Improving Access to Mental Health Act as it relates to Medicare beneficiaries being able to access social workers and the complete set of services they provide, as well as appropriately compensating social workers. And so I wonder if you might speak to that. That seems to me that's a big hole we have here when we're talking about providers in mental health as well, and how could this help meet the demand on behavioral health?
Oh, absolutely. Social workers are critical. You know, as I talked about how hard it is to find providers, they're particularly helpful if you have a chronic health condition or you have a disability and you've got to find multiple providers. Social workers can help you with that coordination. They provide treatment, as you mentioned, and we don't have enough people doing that. So they provide an important role there. They're very important with the social determinants of health, right? We know that housing, food insecurity, transportation, all those things affect people. Social workers can help people get connected and really serve underserved communities who disproportionately are not able to access those kinds of things, and it affects health and mental health. And they're important in integrated care, which we've talked about today. They provide some of those services, they coordinate care. So social workers have an important role to play, and we definitely need them in that continuum of care.
Thank you so much. In limited time, Dr. Trustman, just a couple of things. One, in our discussion draft on workforce, Senator Daines and I proposed raising physician bonus payments in shortage areas and allowing non-physician providers to receive bonus payments, really focused on rural and underserved areas. Any thoughts on that? And also CCBHCs, you know, any comments you would have on that as part of what we need to be doing?
Senator Stabenow, yes, and yes. The short answer, clearly. Having additional compensation and encouragement for people to join us in rural areas is phenomenally valuable. Helping them pay down their sometimes profound student loans, hundreds of thousands of dollars, is an enormous incentive to allow them to do what they want to do in the first place, but frequently can't because of their financial status. And with regard to the new access issues and opportunities, these are phenomenal programs. Our challenge will be, where do you go for an FQHC? Where do you go to these? You know, when do you go in network? When do you go for Medicaid?
Right.
Helping us understand what's
Right.
what.
Well, the great thing is FQHCs and our mouthful, CCBHCs, are now funded structurally the same. It's the same. High-quality standards, full Medicaid reimbursement, and so on. And what we're seeing is that they are oftentimes together at the same site, which is really the long-term goal. Thank you, Mr. Chairman.
I thank my colleague. Senator Casey is going to be next. And just so we're clear, after Senator Casey, the next would be Senator Brown and Senator Bennett in order of appearance. Senator Casey.
Mr. Chairman, thanks very much, and happy birthday.
Thank you.
I know that might have been indicated earlier.
Thank you.
I won't sing, don't worry about it. I want to thank the panel for being here, and I'll direct I think I have two questions for Ms. Giliberti, and I just wanted to thank you and the whole panel for the work you're doing. As many of you know, so many of our colleagues in both parties support making investments to shore up the number of mental health providers and integrate physical and mental health. Last year, for example, last Congress, I should say, Senator Cassidy and I introduced a bill called the Healthcare Capacity for Pediatric Mental Health Act. It was a bipartisan bill to increase investment in children's behavioral health integration, also workforce development and health system infrastructure. As your testimony indicated, so many people don't have access to that integrated care yet, and the process of finding a mental health provider can be overwhelming for people suffering from mental health challenges. Someone who needs help has to sort through provider lists and make lots of phone calls to find a provider with affordable pricing and availability. I know you've covered this. It's especially hard when these lists have countless errors in them. One constituent who reached out to my office was already very well acquainted with a top health system, but it still took her months to find a mental health provider for her daughter. As you indicated, you get calls from family and friends for that kind of help. So I guess my first question is, how can we work together to help people find the provider who has both availability as well as one that accepts insurance? And I know this is by way of reiteration, but I think it bears emphasis.
Yeah, I think that, well, just to talk about integrated care for a moment, if you go to primary care, most of those are in network, right? So that's a way that if we could expand that, we would have more providers that it would be easy for a family with a child, they'd already be there to be able to get that care in network. So that'd be one way. But then, of course, we need these directories to be accurate. So we need audits, we need them to be using their claims data. If there's no claims, they're not seeing people, right? With the shortages that we have and the mental health crisis for children in particular, if they're not seeing patients, we know that they're not in network. So they need to clean up those provider directories, make them very clear, and that will help people find care. And then we need to expand integrated care because I think most families would just love to be able to go to their pediatrician and get the care.
Yep. The other question I had was, how can we help people find primary care practices that offer this integrated mental health care, such as practices that have telehealth partnerships with mental health providers?
I think that would be very helpful to have on the directories when a primary care practice has integrated care capacity. And I think that the barriers that we see often are just that the rates at this point, we just need to put more financing into integrated care as well if we really want to see it happen.
Great. Mr. Chairman, thanks. I'll yield back my time.
I thank my colleague. The next three in order of appearance would be Cardin, Brown, and Bennett. And those three are not here. Let's see. That would then mean Senator Cassidy is next.
Hey, y'all. Thank you for being here. It seems like we actually have two issues here. One is the ghost networking, which could be false advertising. And Ms. Myrick, your experience is so typical. Thank you for sharing it. It takes courage to do so, but just thank you for doing so. Second is access itself, because Ms. Myrick speaks of both, the false advertising and the lack of access. And I think you set the tone for the questions, if you will. Now, one thing that I'm struck by, Dr. Trestman, is when I would speak to, I'm a physician, so I'd speak to my colleagues back home who are in psychiatry, and they would say that Medicaid, Medicare rates were so poor that they got to pay the bills, et cetera, so they typically went to either private insurance or to cash pay. Then I've heard the reimbursement's been mentioned. But one thing that's not been mentioned in this is that traditional Medicare, which actually doesn't have a provider panel per se, that the access is equally poor for the traditional Medicare if you're speaking about something such as mental health providers. Is that a fair statement?
Yes, sir, it is.
I asked my staff, because we did a literature review beforehand, but they weren't quite sure if there had been kind of a crosstab, if you will, of access for Medicare patients, MA versus traditional Medicare. And I wouldn't be surprised if they're kind of roughly the same. Your thoughts on that?
I expect that they are, sir. The challenge in so many situations really is it's the administrative burden, it's the access, the management, and so I think that the MA versus Medicare plans, traditional, have some of the same challenges.
Now, theoretically, an MA plan, if they're challenged to increase their provider panel, they could actually pay better than Medicare rates in order to achieve that. If you will, the Medicare MA model, if done right, actually addresses the market issue, correct?
Absolutely true. And supply and demand is what this country was built on. But I don't think that that has applied appropriately to insurance plans. I think that part of the challenge for us is to come up with an appropriate strategy where people, psychiatrists have told me repeatedly that I wish I could afford to be in the insurance plans, in Medicare, in MA, but it costs me more to deliver the
Oh, I get that. Believe me, I hear that too. So I'm not disputing that. Dr. Resnick, as you kind of representing the entirety of healthcare, at least physicians of it, you could speak to this. There's also a little bit of a quandary that a doctor will see a Medicaid patient because her friend asked her if she will see the Medicaid patient. She doesn't really see Medicaid, but she's going to see this particular Medicaid patient because her friend asked her to. And so she remains on the Medicaid provider panel, but she doesn't really see it. And I think Ms. Gilberti said something along the lines of they're not seeing patients, so therefore they're not in network. Technically, that's not necessarily true if I will see 3 patients a month on Medicaid because my friend, who I've known since we were both in kindergarten together, calls me and says, please see this patient for me. Would you accept that as a valid kind of occasionally occurs at least?
Yeah, I think, thank you, Dr. Senator Cassidy. You know, I have such pride in my colleagues on the front line around the country who are doing their best every day to take care of their communities and the patients who present and the primary care colleagues who call to refer those patients. But as you have identified, payment rates are an issue. And, you know, we have, as we've talked about, 2 decades of stagnant rates in traditional Medicare. We have Medicare Advantage plans in some markets that are so consolidated that they're paying less than Medicare rates.
So let me ask you this. You know, my wife, who's a retired general surgeon, once said if they pay you below your cost, you can't make it up on volume.
That is true.
And so, but to that point, and knowing that there are people who, yes, I am on the provider panel because I still have some patients whom I see, and I will occasionally see a new patient under certain circumstances, it almost seems though that we have to have some sort of threshold to analyze this. Does a patient, yes, they're open for new patients, but how many new patients will they receive a year from this particular payment plan? Because I think we have to bring sophistication to this analysis as opposed to insurance plans are all bad, for example. Your thoughts on that?
Well, there are physicians on panels who have not seen any patients for years, and so that's fixable by the health plan. If it's a small number, then I think we need to turn to the physician. And there's a difference between being contracted, and we see this also with physicians at multiple locations, right, where they're contracted at 30 spots in case they go there, but they wouldn't want to be listed on the directory because they literally go cover for a colleague every couple of years. So I think this is where having a low burden way for physicians to have input and actually be able to tell the plans when and if they want to appear on those directories based on whether they're accepting new patients in that plan.
Well, so with my last, I'm over time, but in 5 more seconds, send me that low burden way. If AMA's got a way to do that we could somehow add sophistication to this analysis, we would like to hear from the frontline providers.
We will be convening stakeholders to help you to that point.
I appreciate that, and I yield.
Thank you, Dr. Cassidy. Senator Cortez Masto.
Thank you, Mr. Chairman, and thank you to the panel. It's a great discussion. I had the opportunity to listen in my office to a lot of the discussion this morning, particularly the integrated model concept that we are talking about today, and was so appreciative of my colleague, Senator Cornyn, asking Dr. Trustman the question about why it's important, and that's where we need to start, obviously. But let me ask you this, Dr. Trustman, how would this integrated model help us alleviate the existing workforce shortage, would it?
I think it'd go a long way to helping, Senator, and thank you for all of your work in this domain. The opportunity is this. If we partner psychiatrists with appropriate support staff, embedding into primary care, we can keep people in primary care without them having to physically be seen by psychiatry. One psychiatrist for 2 or 3 hours a week can review a panel of between 40 and 60 patients to provide adequate support to the primary care team so that we can give guidance and support them. Additionally, something that was already addressed was workforce burnout, keeping people in play, keeping them satisfied with their work. It's morally frustrating not to be able to refer someone to care. If you're the primary care doc, you see someone who needs care, it's beyond your scope, and you can't do it. The collaborative care model and other potential models allow primary care to do what they want to do.
Thank you. And Dr. Resnick, I appreciate your comments regarding the burnout issue and the pre-authorization. I just had some doctors in my office talking about the concerns about this prior pre-authorization requirement and how frustrating it can be. So thank you. But can I jump to, I only have about 5 minutes. I want to jump to rural Nevada, which is similar to Northern California. And so let me, Dr. Rideout, let me ask you this, because as with the integrated primary care, telehealth has proven to be valuable tool for rural Nevada in my state, and essentially to also extend our mental health workforce. And while we're making steps in the right direction, I am concerned that the telehealth and expanded primary care alone will not meet our workforce needs, particularly in our rural communities when it comes to behavioral health professionals in the long term. So in your view, how are contracting issues driving the supply problem in rural areas? How do we address that?
Well, I would agree with you that despite the huge uptick in telehealth visits, it's not going to be enough to solve the supply problem. And as I think a number of panelists have mentioned, primary care physicians, and I'm one of them, do provide a certain level of mental health care, but they too are burning out. They too are aging out. So you've got essentially stopgap measures. And I think in terms of contracting, in my experience across plans, purchasers, and providers, it's the conditions of participation, including rates, but not limited to rates, that really drives whether people want to participate or not. We've heard that psychiatrists, which are actually a relatively small percentage of the total mental health providers, it just costs too much to do it. I would bring back a thought of integrated care. We've talked a lot about integrated care in terms of medical and behavioral integration. There's also an integrated care model where physicians of multiple specialties practice under one organizational structure in an organization that's large enough to provide telehealth, large enough to provide data analytics, and large enough to essentially cover some of the shortages through better contracting or better load management within the group. So I think that's hard in a rural area because people don't concentrate that way in terms of practice. Very, very well.
Thank you. Dr. Resnick, did you have a comment?
Well, Senator, I'm really glad you brought up contracting, because when we look at the data, and AMA produces these data every year, most areas around this country have highly concentrated insurance markets where one or two plans cover the vast majority of patients in that area. So they're really, in rural Nevada or in big urban centers, there's not meaningful contracting. And we have physicians who have a big panel of patients, and the insurer just sends them a letter at the end of the year that says, thanks very much, we're done with you. Or it's really take it or leave it contracts that they present that increasingly are lower and lower percents of Medicare. So it is not a level playing field between the physicians who actually want to be contracted to be able to take care of their patients and the health plans.
Well, and it sounds like we need another panel of health plan providers to be able to talk to, and I look forward to that opportunity. Thank you, Mr. Chairman. Thank you.
Thank you. Senator Brown will be next, and I understand one of our colleagues on the Republican side is coming back as well. But with that, unless there are people we don't know about, we will wrap up, and there's a vote on. Senator Brown.
Thank you, Mr. Chairman, and I'm glad I got here in time. Welcome, all of you. Thanks for joining us and for the service you provide to so many people. And it's more important than ever. I mean, we all, living through the pandemic, we're all saw different parts of the healthcare system, perhaps, and it's more important than ever that people in my state, in Nevada and Oregon and Idaho, get the mental health care when they need it. And we know that we didn't pay enough attention to mental health during the pandemic. Mental health, it's fundamental basic health care. It works, it saves lives. Too many families, though, as you know, can't get this life-saving care. Finding someone to help is hard enough. Trying to call for an appointment with a doctor who doesn't exist or doesn't exist at this number and is a so-called ghost. We agree we spend too much time trying to schedule doctor's visits. For most people, it's far too troubling and difficult, and Rube Goldberg liked to get through. The problem worsens when we can't be sure that the doctor listed in the insurance directory is actually practicing medicine in the place that we think that person is. And doctors listed aren't taking patients sometimes. Other cases of doctors have retired or practicing in an altogether different location, sometimes in a different state. And so I mean, it's infuriating. It's also preventable. So, Dr. Trestman, what should Congress do to make it easier for you to work with plans to make sure they have the right information? How would you feel if you tried to call a doctor only to realize the number? I mean, you know where I'm going on this, so talk to me.
Thank you, Senator. You know, to be very trite, this is complicated. There are many, many opportunities, but I do think some of the things we've heard today are really critical. The first, if Congress could pass a standard that everyone shares to reduce the inconsistencies in format and reporting time and sequence. The more we can have consistency and essentially interoperability, making it electronic, making it as close to real time as possible would be of enormous benefit to everyone. So I think that some of the things that Dr. Rideout mentioned in one form or fashion could be transformative for our nation. If we have a standard, that would really reduce some of the challenges. Sharing the burden between the physicians and the insurance plans so that, we own responsibility of, how many patients can we see? How much can we afford to see of which plans? So, but I think that a standard that would be federally structured and guided would help all of us. Thank you.
Thank you, Dr. Schwartz. Ms. Meyer, kind of along those lines, let's continue down that path. First, thank you for sharing your story to this committee. That always takes guts to talk about personal stories in public and Congress. No one should have to fly, of course, no one should have to fly across the country at her own expense because she can't find a psychiatrist to treat them. Ohioans just want to get the treatment they need using the benefits that they actually paid for. Several years ago, we passed a law making sure patients are held harmless when they relied upon an incorrect insurance directory. Sadly, patients must file an appeal with their insurer, the same insurer that made the error. So, Ms. Giliberti, isn't this appeals process just one more annoying, time-consuming, I hate to use the word Rube Goldberg again, but kind of is a hurdle that Ohioans and others shouldn't have to face when they want to get mental health treatment?
These kinds of processes can also be very difficult for people. So we talk a lot about making sure people know their rights. It's clear. We've been talking about financial protection. If you use somebody in a directory, that should be really clear to you that you have a right to get that reimbursed. So we need to make things clear to people, and I agree that a lot of these procedures wind up making it difficult for the person and the insurance companies really need to bear the burden here.
Thank you for that, Mr. Chairman. Thank you.
Thank my colleague. Senator Langford is next. Oh, excuse me. Senator Warner is next. And we're going to go in order of appearance. Senator Warner is next.
Well, thank you, Mr. Chairman. And I'm sure others have already mentioned this, but happy birthday. I really do appreciate the fact that you and Senator Crapo are holding these hearings. I mean, this issue's around mental health. I think we always knew it was a huge issue, but in a post-COVID world, I don't know any family, including mine, that doesn't have some challenges around mental health. I want to also acknowledge Ms. Giliberti and Dr. Tressman, who are both service in Virginia, and we've got a lot of great talent there. I wanted to raise quickly, I'm going to go to Dr. Rideout on a question, but I want to brag for a moment about something we started in Virginia way back in the 90s. I'd started something called the Virginia Healthcare Foundation, and then subsequent to that, seeing how my dad was trying to take care of my mom and access services, we started something called Senior Navigator, of how you can, provide in the kind of directory issues we're talking about on a real-time basis, linking up services. That Virginia Senior Navigator program grew into something called Virginia Navigator, and it's now up to 9,000 service providers who provide 26,000 programs, and we've kind of taken this high-tech, high-touch approach. And, it's one of the things that kind of makes me crazy that these insurance companies and providers, don't update. I know everybody, this has been the focus of the whole hearing about how you update these directories. How do we make sure there is that navigator role rather than simply putting out a tech site? Dr. Rideout, I know you've had some experience in this, and how do we do a better job on these high-tech, high-touch approaches? So we can get the incentives right so that people can access these services out of these directories in a user-friendly way.
I'd answer that, Senator Warner, by saying I don't think it's the tech or the touch that matters. It's the quality of the information and the willingness of the participants to share that information before it gets published. I know there are many ways to do that, but in our experience with Symphony, you have to get it right before you start pushing it back to the plans or the providers as right. And then if the patient is experiencing a disconnect, they aren't taking a new patient when they said they were, then you can resolve those, I think, on more of these one-on-one basis. But I think if the core problem is 80% of the information is wrong to begin with, I don't know that technology is going to solve that. And I think navigators are great. We've used those in many settings in healthcare and housing and other things. But then you have, is the energy of the individual to kind of hang in there of the navigator better than the patient? And the answer may be yes, but they may not have any more success.
But don't you think even if you get the information right, the amount of time that that information stays right is going to be a short term? So one of the things I think that is important is, I agree with you, you got to get the information right, but boy, oh boy, you also got to make sure that there is an update process. And have you found experience with Symphony, how you make sure that data is constantly updated?
We update pretty much weekly, and then physicians attest at least every 3 months because they only have to attest once. Imagine if you were having every health plan and every large provider organization ask the same physicians the same information over and over and over again. A lot of times they'll just stop providing it. So I think you have to do it very frequently, not quite real time, but pretty much closer to that to get it right.
And Ms. Gilberti, I was interested in your testimony when you said that there was a California consumer protection law that basically said, if a plan doesn't provide these mental health services, there's almost a consumer protection law that says the plan has an obligation to define that services. Has that been a good way to keep the plans a bit honest? Or?
I think it's a relatively new requirement, Senator, but the idea is that they have to arrange for it, and then if they can't find it in network, they have to pay the out-of-network charge for the person that they found, the provider that they found. So like you're saying, it takes the burden, again, off the person.
Yeah, it shifts the burden
to the plan to help you find it. Again, though, it has to be really clear on your directory that they can provide this help to you, right? Because otherwise people won't know about it. So I think it's really important that people know about it, and then they're actually going to be able to get that kind of help.
Well, I do think, and again, where I may take a little issue with Dr. Rideout's position, because I do think you got to get the information right. But Lord knows, there are plenty of user-friendly sites that invite a user in, don't make it this technology opaqueness. And I think, again, there are examples across the spectrum that we can look at for best practices, but I do appreciate the chair and vice chair holding this hearing.
Thank you, Senator Warner, and you're being logical, and heaven forbid that logic should break out over this, because I too believe in these navigator approaches. The reason this has been an important issue is there's been a misrepresentation, not something that spells out what you're talking about. So we're going to look at it. Senator Langford.
Thank you, Mr. Chairman. Happy birthday as well. And thanks for holding the hearing. Yeah, so y'all, thank you for the testimony today. Exceptionally important to be able to get out there. All of us deal with this. We all have casework staff that try to help chase through things, so we hear it as well. This is really important that this gets out, and we find ways that are practical, realistic ways to be able to actually process this. Dr. Resnick, I want to try to drill down a little bit from the physician side of this. So insurance plan reaches out, let's say early summer, and says we're looking to be able to put all of our networks together for next year. You want to be in network or out of network? They negotiate you. They tell you this is what we're going to pay you flat out, and no, we won't negotiate with you. And you go through all that back and forth on it. Finally resolve it by the end of the summer. They put out their open season plan with their list of all their providers on it. For the next year, people select their plan based on who their providers are, if it's near them or their own physician is there, and then they pick up the phone and start calling people. Is there a requirement for physicians, if they say I'm going to be in a plan, to actually be in that plan for the next year? Or can a physician say, yeah, I'll be in the plan, and then let's say January, February, March decide, nah, I really don't feel like being in this plan? Are they locked in typically? And again, company to company may be differently, but is there a commitment on the physician side? If I said I'm going to be in this plan for a year, I'm actually going to be in a year.
In general, physicians contract on an annual basis, but I think this probably varies by state and by type of plan. And we see plans terminate people mid-year for no reason.
Right.
So there's the other piece of that as well. But we'll get back to you with more information.
That's right. That's helpful, because that's one of the areas that we've got to be able to resolve is there a commitment from the physician also to be in the plan? We've heard several times from different plans that will say, or from individuals that will say, By the time that I actually pursued the plan and got into the plan and started in January, February, started calling people, they said, oh, no, I actually dropped out last year, but they're still listed, or I just changed and shifted over. And we're trying to figure out the mechanics of where are all the players in that.
And if you talk to that physician, they probably called the plan just like your office staff helping people in your district, in your state have, and probably sat on hold for 3 hours and then got disconnected trying to update the directory themselves. So the plans have made it really difficult for the docs.
Yeah, really difficult for the patient and for the docs on it. And that's what's been the challenge on this. So the next layer on this, Dr. Ryder, let me ask you about this as well. From the industry side, and you're dealing with this, there's a lot of insurance companies right now that aren't following the current CMS regulations even. So the issue always comes back to us. They're not following currently. Let's add one more and see if they'll follow that one as well. What do you see as the solution here in this process? Because I don't want a single constituent to be able to call and say, I don't know who that is. Ms. Meyer's testimony was powerful to be able to say, don't know who that is. That person died. Sorry, we don't take people anymore. We haven't been on that for years. That's plans just not updating and doing their work, but they're already violating CMS rules. So from an industry perspective, what's the answer on this?
Standardization across the board, and that's a challenge because most plans are regulated on a state basis, and states have their own variations on what they do or don't want. But I think it starts with very, very detailed aligned standards. You know, and the old adage is standards are great because there's so many of them, and that's the problem. We're now dealing with, you know, Medicaid standards, CMS standards for Medicare, Medicare Advantage, state standards. So it's...
Yeah, there are state regulations, but this is a Medicare Advantage. This is a unique, this falls right into this committee of what's happening in Medicare, Medicare Advantage and such, so to create that centralized standard for that. Dr. Resnick, were you want to say something?
Well, your colleague earlier mentioned carrots and sticks and liking carrots, and I completely agree. Transparency would be great. Carrots are very helpful. My fear is I'm going to be walking around with a backpack of carrots for another 10 years, and they're going to rot in my backpack because I won't have any to give out. The plans are so consolidated and have such an incentive to look like they have a full network when they don't. That I think in the Medicare Advantage space that you have jurisdiction over, and in the exchange space that you have jurisdiction over, we do need some sticks. We do need monetary fines. These are big plans with big resources that have the capability and responsibility to put out accurate directions.
So the sense would be, like the chairman was saying before, if we end up calling a secret shopper type calls or whatever process that we do from a third party or whether it be a federal entity and find out, no, these folks don't actually exist, then they get a fine to be able to come in. So it's a requirement on them to be able to fulfill that.
Right. There's always going to be a little background noise and a few inaccuracies, but when 80% of the directory is inaccurate, I think you can say that is a planned failure.
That's a massive issue, and it's a big issue for us in rural Oklahoma, that there will be companies that will put out a plan and that everyone looks at it, selects a plan, then they get into that plan in January and find out it's not real. And they can't go anywhere. Or if they're going to go anywhere, they're going to have to drive 150 miles to be able to get to someone. They assume the people that were listed locally actually existed and accepted the process. So appreciate your testimony today.
And Senator Langford, you have just given a snapshot of why this issue is so important in rural America, and I appreciate it. Senator Menendez is next. Excuse me. Senator Whitehouse is next.
Thanks. I'll be very brief because I know Senator Menendez has a lot to do, but I wanted to flag, it's not exactly the topic of this hearing, but it's been extremely important in Rhode Island to have had mental health access through COVID through telehealth. It's been extremely important with people who are in recovery to be able to talk to their peer recovery coaches and to the people who are providing them treatment. And I just wanted to take a moment. I'm seeing a lot of heads nodding that this is a good thing, that we need to extend those telehealth protections and waivers, because the information that I have is not only did compliance, attendance improve compared to having to come into the office, but I know this is anecdotal and there's no way to put a scientific proof behind it, but over and over again I've heard from the professionals in the community that the quality of the engagement increased with telehealth. And I suspect that's just the human aspect of not having to drive someplace, not having to wait in a waiting room, not having to fill out a clipboard, not having to be in unfamiliar territory. Instead, you just go to your quiet place in your own residence, you click on, and there you are. So I wanted to make that pitch. I also wanted to try to make the point that this problem of required networks and fake networks, in essence, is part of a suite of payment and cost-saving strategies that have developed in our current healthcare system. They include just plain payment denial and delay. We have an enormous armada of insurance effort to slow or deny payment to providers, obliging providers to then stand up a whole countermeasures apparatus. I remember years ago going to the Cranston Community Health Center and finding out that they actually had more personnel on staff who were devoted to trying to get paid than they had devoted to providing the health care that the Cranston Community Health Center provided. So there's an enormous, enormous burden of unnecessary administrative cost from that. There's an enormous burden of administrative cost and pain from these fake networks. And I think that prior authorizations are another vehicle frequently used by the insurance industry to evade and avoid payment for services that are pretty clearly required. And what I would really like to have anyone who's interested do, and you can do this as a response in writing, consider this a question for the record, I think the way out of most of those problems is comprehensive payment reform. The more we get away from fee-for-service, the less ability there is to deny and delay the payments for those services, to shrink networks, and to impose prior authorization restrictions that foul up treatment. So we're continuing to work to get that done here. I think the ACOs, the Accountable Care Organizations, provided a good lead that have provided, particularly in Rhode Island through Coastal Medical and Integra, some really good results showing what's possible. But I'd love to have your careful thoughts on that. And is this area of reducing the deadweight cost burden of the administrative warfare between insurers and providers likely to be alleviated by payment reform? And if so, what payment reforms are likely to alleviate it most? And with that, I'll yield back to Senator Menendez, I guess. I'm not sure who's next. Senator Cardin.
We're going right up the line here. So first, I want to thank you all for your testimony. Now, I just really want to add one other dimension to these ghost networks. My colleagues have heard me talk frequently about the tragedy in dental care with DeMonte Driver losing his life in 2007, a 12-year-old, because he couldn't get access to dental care. I know that our focus here is on a broad range of services, particularly mental health services, but DeMonte Driver's death was many contributing factors. One was that his mom really could not find a dentist who would treat him. There was not an accurate directory available that could provide guidance where she could find a dentist who would be willing to provide services. And I guess what I just want to underscore is that this topic is critically important for healthcare throughout our country, but particularly in underserved communities. They need help. And if we don't have accurate directories, if they have a list that is not accurate telephone numbers, or the provider is not taking any new patients, and it may be somewhat redlined, it makes it even more challenging. So I just really wanted to add that into the record, and I thank you all for your participation. But as we look at ways to solve the issues, let us not lose sight of the fact that it's not equal throughout this country. Underserved communities are suffering the most. And with that, I'll yield back.
Thank you very much. The problem of ghost networks is particularly harmful in mental health care, and one arguably made worse in recent years. Amid the nation's ongoing mental health crisis, though, the pandemic and beyond, those desperate for help continue to get ghosted. And reality is that there just aren't enough providers. I was proud to secure my colleagues on the committee 100 new graduate medical education slots reserved for psychiatry in last year's Consolidated Appropriations Act. Last week, I reintroduced my Resident Physician Shortage Reduction Act alongside Senators Boozman, Schumer, and Collins. It's a bipartisan bill would raise the number of GME positions by an additional 14,000 over 7 years.
So, Dr. Resnick, would you agree that increasing graduate medical education positions would complement efforts to improve provider directories and mental health access overall?
Senator, I cannot thank you enough and agree enough that, and the 100 additional slots for psychiatry, every little bit helps, but the larger act is absolutely necessary as we face an aging population. We need more physicians for this country, so thank you.
Thank you. Dr. Trestman, for children in care of need, the problem's even worse. According to the data by the American Psychological Association, only 4,000 out of more than 100,000 U.S. clinical psychologists are child and adolescent clinicians. What can Congress do to specifically address the workforce shortage of child and adolescent mental health clinicians?
Senator, I think that the trajectory that you and your colleagues have started has been wonderful. We need to think broadly about the needs of healthcare in this society, and so training at the community college level, the college level, getting people in the pipeline for allied health professions, whether it's nursing, social work, community health workers, as well as psychologists and physicians. We need to think broadly so that we can provide adequate care, and many professions other than physicians can be trained in a more timely way, and any of the ability that they have to provide care, whether through social work or others, can make a profound difference and really expand and leverage the care that only physicians can provide.
Mm-hmm.
Thank you.
Mm-hmm. Well, imagine for a moment that you or someone you love is in the midst of a mental health crisis. You call 70-plus doctors listed in your insurance plan's network. Not one is available for an appointment within 2 months. Most never call you back. Some are retired. Others are deceased. Some phone lines are disconnected. This is the reality for far too many people seeking mental health care services in New Jersey and across the country. It's critical that people seeking mental health services have access to accurate, up-to-date provider directories. This outdated information hurts people when they are desperate to get help for themselves or a loved one. Ms. Gilberti, what mechanisms can federal regulators use to hold those responsible for providing, for provider lists accountable? How can we highlight how CMS can better enforce regulation and oversight of provider directors?
I think they could do several things. One, we could have audits of these plans for their behavioral health networks, and those audits could be done either by CMS itself or by a third party, and transparency, right, the results of that. We've also talked about making sure it's included in the star rating system so that it's really, they get incentivized to make those changes. And we've talked about civil monetary penalties, which currently don't exist, right? So that's another way, and they'd have to be sufficient to affect behavior. So those are an array of choices that could make a difference if they were combined together.
And finally, we have to address the challenges of ghost networks, but we must also prioritize policy that support low-income and marginalized populations. Last week, HHS released proposed access and quality standards for Medicaid and CHIP. Among other things, these proposals would require states to conduct, quote, secret shopper surveys of Medicaid and CHIP managed care plans to verify compliance with appointment wait time standards and to identify where provider directories are inaccurate. How would these requirements mitigate impacts of ghost networks for low-income communities, Ms. Myrick?
Thank you very much for asking that question. And I think anything that can help, especially folks of color, people in low-income communities, be able to get the accurate information that they need in order to get the care when and where and how they need it, is going to be critical. And I also added that being able to empower the consumer, the word consumer, I actually like it. I know in our community sometimes it's a little. People don't like it, but the reason I like it is I think of John F. Kennedy's Consumer Rights Bill and what he talked about in 1962 about the consumer's rights to be heard, the consumer's rights to have information, to make a choice. And then lastly, the UN added to redress. And I think the things that you're talking about give us those rights, especially if we have something like a 1-800 number or a online portal to report when we are not able to get our needs met because of the ghost network. Because we want to inform too. We want to be empowered to inform so that either the carrots or the sticks can happen. So thank you.
Thank you very much for your insights.
On behalf of the chairman, I call on Senator Blackburn.
Thank you so much. And thank you to each of you for being here. Ms. Myrick, thank you for sharing your story. I appreciate hearing that. I know we're talking about Medicare Advantage, but Senator Blumenthal and I have been busy today introducing the Kids Online Safety Act. And Ms. Myrick, as I was listening to your testimony, I thought how closely it mirrors what I hear not only from moms and parents, but the teens themselves. I hear it from the psychiatrists and psychologists, from principals, that there is not enough access. And that there seems to be complete confusion when you call the insurance company and say, we're desperate for help, I have my child, we're here at the emergency room, we're not getting any answers. And it is just so imperative that we look holistically at this system. And I appreciated hearing from you on this issue. Dr. Resnick, let me come to you, because telehealth is something, even when I was in the House, and we were working on 21st century cures, and then I didn't get my telehealth bill in there, but we got it across the line during COVID. And during COVID, people really began to use telehealth. And what I hear from providers, especially down in Shelby County, Memphis, that area where you're dealing with Mississippi, Arkansas, and of course the Med is there in Memphis. And they talk a lot about interstate licensure requirements. So just very briefly, if you would talk to me a minute about what you are hearing from providers when it comes to that licensure issue, and also what you're hearing about the digital therapeutics and their utilization in these.
Thank you, Senator. My dad grew up in Clarksdale, Mississippi, so I know the Memphis area well, even though I'm now a Californian. And I'm always reluctant to use the term bright spot about anything in the pandemic, but telehealth clearly opening up coverage, whether it's Medicare or commercial insurers, huge bright spot. Thank you for your leadership in that area. And we have seen not only patients learn how to use it well and discover when it's convenient, but we've seen physicians in every specialty, psychiatry included, learn how to integrate it seamlessly into a care plan, because sometimes patients need to be seen in person, and now we know more about when those instances are and when they're not. You mentioned licensure. We still believe in maintaining state licensure and that it exists in the place where the patient is. And the reason we believe in that is because if I'm taking care of a patient in Florida, I believe I have a responsibility to follow Florida's rules, and that patient needs to be able to go to their state insurance commissioner if I provide lousy care to seek redress. But we have some really cool stuff going on to aid in people being able to do telehealth in multiple states. We have the Interstate Medical Licensure Compact, where it makes it much easier for many physicians to just click off several states that they want to be licensed in and agree to follow those rules. We also, lastly, I'll just quickly say—
Is that the reciprocity model?
It's not pure reciprocity, but essentially it's not like the nursing reciprocity model, because individual states do still maintain the ability to police what happens in their states and take your license away. But it makes it much easier to get multiple licenses. The other thing is, we have seen the medical boards, the Federation of State Medical Boards, agree unanimously nationally, and now it has to be implemented on the states, on reasonable exceptions. If I'm taking care of a patient and they go off to college and they happen to be out of state, or they're vacationing or spend 3 months a year in Arizona, that's not really practicing across state lines. I have an established relationship. If a patient needs to go to a center of excellence and wants to do one pre-visit via telehealth across state lines, that should be okay. But we do want to protect patients and make sure they have local care.
You want to weigh in on this? Go ahead.
Telehealth has been transformative.
Okay,
can
you were
only-
nodding your head, and I thought you might want to have a
Thank you.
little
So,
something to
yes,
say.
And the continuing availability, particularly in rural areas, is extraordinarily valuable. But also even in urban areas where it may take people 2 hours to take 3 buses to get to us.
Okay.
And by the way, I trained at the Elvis Presley Memorial Trauma Center in Memphis. So,
God bless you. Ms. Gilberti, I saw you nodding your head.
I was just going to say that I'm very glad to hear about the college students, because we hear that all the time about college students that have a provider and then they lose access to it. And I think that, really this idea really needs to be thought through, particularly for mental health, where, the issues in a state, I really don't understand why we can't get more reciprocity and more ability to go across state lines with mental health care, because it's very problematic.
Increasing access is what we ought to do. Thank you, Madam Chairman.
Thank you. So America is facing a mental health crisis. 1 in 5 Americans live with a mental illness, and for Medicare beneficiaries, it's 1 in 4. Federal law requires Medicare to cover mental health services in both traditional Medicare and Medicare Advantage, or MA, the program that allows private insurance companies to offer Medicare coverage. Now, unlike traditional Medicare, the private insurance companies in Medicare Advantage can establish networks to restrict the doctors or facilities that beneficiaries can use. So if your doctor is in-network, the plan will cover those services for a small copay, but an out-of-network doctor can leave patients with skyrocketing costs. This can be especially devastating for seniors or for people with disabilities who are more likely to be living on fixed incomes. To help beneficiaries avoid these surprise costs, MA plans are required to publish directories which enrollees can use to find new doctors or to make sure their existing doctors are covered. So let's start with what we know about the accuracy of these directories. There have been some references to them, but Ms. Gilberti, did I say it right, Ms. Gilberti? What do we know about the accuracy of the provider directories in Medicare Advantage?
So CMS has done some audits, Senator, and what they found was, on average, the accuracy rate was about 45%. So,
what does that mean, that the accuracy rate is 45%?
They found in 2018, I think it was, almost 50% had at least one inaccuracy. So, we're seeing a good deal of inaccuracies. That's with physical health care. Just say there's a gap in data because they haven't done this for behavioral health yet.
And might we surmise that behavioral health
It's
accuracy.
worse. It's always worse.
It's always worse. It's always worse. Okay, so you think you've got a list of people you can go to, and the odds are actually in favor of the list is wrong, and probably even worse on behavioral health. All right, so here we've got a patient who does everything right. They still may be hit with a huge bill because a directory has outdated or inaccurate information, or they might call up every doctor only to find out that we've heard about some of this. The phone numbers don't work. They're not accepting new patients. I think we've heard the story about this and appreciate your being here to talk about your story, Ms. Myrick. We know that MA plans use all kinds of tricks and traps to squeeze more money out of Medicare. They've got a lot of different ways that they do this to boost their numbers. But here's the one I want to focus on. Do these MA plans stand to gain anything from having inaccurate information? In other words, is it inaccurate because they just haven't spent enough money to make it accurate, or is it inaccurate by design?
Well, I think there are advantages that they have when their directories, unfortunately, are inaccurate. If they use those directories for network adequacy standards, for example, they might meet the standards, but they're not accurate. People make choices based on what they see as their network. So if it looks like a bigger network, but it's not real, people are choosing a plan.
Okay, so it's a way to defraud consumers. To say, I have this really big list of people you could go to if you had a problem. And it turns out that really big list, if it were accurate, is actually this little tiny list. Right? Okay.
Right. And then,
so that's one way. It's to the advantage of the Medicare Advantage plan in order to be inaccurate. They get paid, in effect, or they make more money by being inaccurate. Did you have another one?
Well, just that, I think it's about 60% of the plans don't have out-of-network coverage. So if you get really frustrated and you pay on your own, then they're not paying anything.
So the more I can frustrate you, the more that meaning the Medicare Advantage plan, the more the Medicare Advantage plan can frustrate you, the more you'll just go somewhere else. And that means it's not money out of their pockets. Did we get the two main ones you wanted to add?
I just was going to add, Senator, this is, yes, we see this all the time. This is health plans delaying and denying care. That same patient, once they finally find the needle in the haystack and even get to a physician who's in network and sit down and get a diagnosis and a treatment plan, then goes to the pharmacy and discovers the health plan requires prior auth for the treatment for that condition, which then it takes weeks to get approved. Sometimes they never go back to the pharmacy. They give up. Their mental health or their other chronic condition gets worse.
So conditions get worse, and they don't have to pay for the treatment, this Medicare Advantage plan. So look, what we're really saying here is that it is in the financial interests of these Medicare Advantage plans to discourage beneficiaries from accessing care. We also know that the Medicare Advantage plans are paid a set amount per beneficiary, which can be dialed up if the beneficiary is sicker. So the more diagnosis codes that a beneficiary has, the higher the payment. The insurance companies have built entire businesses around making these beneficiaries look as sick as possible and then overcharging taxpayers by hundreds of billions of dollars. Because here's the key that underlines this. Whatever insurers don't spend on care as a result of tactics like outdated provider directories or overly restrictive networks or inaccurate information, whatever they don't spend on care, they get to keep. So let me ask you one last question on this. What penalties, Ms. Gilberti, do MA plans face for being out of compliance with regulations and provider directories and network adequacy? So we got a bunch of rules. When they're in violation of the rules, what's the consequence?
I'm not aware of any penalties, Senator. The audit that I mentioned earlier talks about like notices of noncompliance and warning letters, but they don't mention anything about penalties. So I know there's been some legislative proposals to that effect, but I'm just not aware of any penalties that are being assessed.
I tell you, nobody's jumping in with any other answer. You know, this is the part that just drives me crazy. People look at the regulation, they think, oh, well, we're going to be okay because this is regulated. But we're not okay if there's no enforcement. Now, to the extent they have enforcement tools, CMS really needs to step up the enforcement here. At a minimum, beneficiaries should not be on the hook for out-of-network costs that were incurred because of inaccurate directories. That'd be a nice starting place on this. CMS should also penalize Medicare Advantage plans that are out of compliance. Just put penalties on these guys. And it's Congress's job to put tougher regulations in place. And I also want to say this. If these Medicare Advantage plans continue to mislead beneficiaries about covered providers at the same time that they are overcharging taxpayers for this crummy coverage, then we should be taking another look at whether or not MA plans should continue to enjoy the privilege of restricting provider networks at all. Now, there's a serious question that should be on the table. If they can't do better in managing these restricted networks, then maybe they ought to have to cover anyone who's a licensed practitioner that you go to see. So with that, I will now say I'm finished, and I will put on the hat of the chair and say, without objection, I would like to submit the majority staff report into the record. Anybody object? No. Senators have 1 week from today to submit questions for the record. Those will be due at 5 p.m., and this hearing stands adjourned. Thank you all.